In 2004, after realizing the financial barriers that survivors faced in terms of accessing preservation, Fertile Hope, the organization, developed a program previously known as Sharing Hope, which is a financial assistance program focused on identifying reduced preservation options for people in the community, and we'll talk a little more about the details of that program later. In 2009, the decision was made that the Livestrong Foundation would acquire Fertile Hope, the organization. And this happened for a number of reasons. Fertile Hope, Lizzie and her team did a great job in terms of raising awareness that fertility and infertility is a risk of cancer and its treatments. And so because of that, more and more survivors as well as doctors were aware of this, but it really needed to go over a hump. There's a lot of conversations happening, but it was felt that an organization like ours would be able to provide a more comprehensive overview and approach to our fertility work in the community. And with our broad reach and with our navigation services, it made sense for us to acquire this organization to be able to provide more specialized education and information around fertility. That was in 2009. And then in 2012, we structurally, internally made the decision to have a more robust team here within the foundation, within navigation, but also across the organization as a whole to focus on fertility work. And so we'll go over some of the details.
Great. So 2012 was a very exciting year because I got to transition into my role as the navigator for fertility services. And so just to give you a glimpse of these are all of the team players that have a hand in fertility work. And so I oversee the day-to-day aspects of our financial assistance program related to fertility. And we also have Jamie, who has come on board as a contractor, and Jamie can raise her hand, she's right there. She started in June and will be here through December. And then we have Anne, who's also in here today, and I saw her. Maybe she had to step out, but she has been here spring and this summer, and then Kelly's a new intern that we have on board. All of us work directly with clients in the fertility centers and just things related to our fertility financial assistance program, and then also some other projects. Emily oversees national services and has been a part of fertility since we have acquired it in 2009. And then both Sarah and Lois also have a hand in fertility. They're working with our fertility advisory committee and then also the fertility training that we'll talk about later. And Lois working with our health policy and insurance reform work and trying to get coverage for fertility preservation. And then not to leave out, we do have our general navigators, which would include Indira and Guadalupe and Abby, who all educate on fertility preservation risks and options whenever they're talking with clients directly. So we'll start with a trivia question.
All right. So I'll read this out loud, and this is a true or false question. Pre-treatment fertility levels, treatment type, and age are all factors in determining a patient's risk of infertility. True or false? First to raise their hand and answer correctly gets a prize.
Yay!
We get a lovely prize from our Vanna White over here.
It's a phone skin. Get excited. It's a sperm.
Does anybody have any questions associated with any of these specific factors at this point? And actually, we'll give you some more education on it. Yeah. Oh, go ahead. Sorry.
Is one more important than any of the others?
Really, it's all a combined factor. So many people, so for example, cancer type, which is also not listed on here, is also another risk factor. And so you have to take into all of these things into consideration when you're looking at one individual's risk. So it's we can make generalizations, and some treatment types are more severe than others. Some types of cancer are more severe than others in terms of impacts to the reproductive area, but you really have to take into consider all the different aspects for the one individual to determine their risk. Yeah.
What about patient's sex, like if they're male or female?
Yeah, so that impacts, of course, some of the cancers that people get. So, for example, testicular cancer and then ovarian cancer. Those in and of itself are diseases that will impact the gonadal function of somebody. And so, yes, that is definitely a contributing factor.
And the outcomes for both men and women after treatment are different, so we'll talk about that a little bit too. So we'll go over the need for fertility preservation and why this topic is so important. And it is because of the number of people that are diagnosed in their reproductive years every year. So that's 130,000 cancer survivors that are diagnosed with cancer could potentially have an impact on their fertility. We've learned that the ability to have children in the future does impact someone's decision on what treatment they might have, or they might weigh out their treatment options a little bit differently depending on how it is going to affect their fertility. As Emily said, risks to fertility vary on the cancer type, the treatment, the dosage, and also your pre-treatment fertility levels. So we could all go and get our fertility levels tested now and have an idea of where we are, and that's the same for anyone diagnosed by cancer. They could have an idea of where they are prior to treatment, and then again after treatment you could have an idea. There are options that exist that we're going to talk about today that are for fertility preservation or for family building options, pre-treatment, some even during treatment and then after treatment. And we have found that the cancer survivorship rates are generally high. So 77% of patients under the age of 45 survive at least 5 years. So many more years beyond 5. So Emily's going to talk a little bit more about impact.
Yeah. So just to go into some of the reasons why it's so important, and we feel like it's a very important job of ours to educate providers and patients about the impact that fertility has, because it does impact somebody's quality of life, not only when they're just diagnosed while they're going through treatment, but also years and years after treatment. So people who are of reproductive age want information about their options. We hear consistently from people who weren't educated and didn't realize that their treatment was going to cause them to be infertile afterwards, and it causes a lot of undue stress and regret on their part. Not knowing and having information is something that we want to make sure that we do something about. The majority of oncologists, unfortunately, do not discuss infertility and options for preservation on a regular and consistent basis with patients. There are studies done about not only on the education level, but also the information level. So I'll explain a little more about that. So there was a study done in collaboration with Moffitt that was talking about asking oncologists how educated they felt on fertility and the impact that cancer has on fertility. Most said that they felt educated and they had the information. But then when asked how often they educate their own patients about it, the percentage dramatically decreased. So we want to make sure that we're bridging the gap and letting sure that oncologists are not making assumptions about a patient's situation, about what their financial capacity is to do this, that they are actually educating survivors about this risk and their options.
Next, we're going to talk about some of the barriers to fertility preservation. So treatment and timing is huge. There are major differences between a man preserving his sperm and a woman preserving her eggs. So a man could go same day and go to a sperm bank and bank his sperm. A female, on the other hand, it could take 2 to 6 weeks. And so timing, is the doctor going to be okay with them delaying their treatment anywhere from 2 to 6 weeks? Some are not. And so we do have those conversations with women about what happens if they are rushed into treatment. We have women that close applications all the time because they don't have enough time to preserve. And so then we have to talk about options after treatment and what could be possibilities, but that can be a very emotional conversation. Again, limited education on risk to fertility. So someone's just diagnosed, they're sitting in their doctor's office, and if their doctor doesn't mention it, they're thinking about all of these other things. Fertility might be the last thing on their list that they're even considering, especially if they're 16, 18, 24. They might not have a partner. They might not be thinking about kids at all. So if the doctor's not telling them or a nurse is not telling them, then maybe, who is telling them? Maybe no one's telling them. Not knowing about the options, so not knowing that there are options available. There are options available for young boys and girls that are prepubescent, that maybe they haven't hit puberty yet, and the traditional options, more standard options, aren't available to them, but there are things that they can do to preserve their fertility for the future. Financial costs. It can be very expensive. They've just been diagnosed with a cancer diagnosis, which means medical bills, all left and right coming to their mailbox. So can they afford the cost of preservation? Age is going to be a huge factor, so it's going to be very different for someone who is 18 versus someone who's 45 or even older. And then physician assumptions, and this one talks about why are the doctors not talking about it in their office? Are they making assumptions that, well, and they can, that if the patient doesn't mention it, maybe they're not interested in it, so then they just don't bring it up. Or maybe this person's already come in and they're already on a government program, or they're on a state Medicaid, so doctors know it's expensive, so are they really going to bring up an expensive procedure that their patient maybe couldn't afford? But they might not know that the person's family would all contribute and could help them make this possible. So there are physician assumptions which keeps the patients from getting all the information that they need. Any questions? Okay, we have another trivia question. I'm excited. All right, sperm banking after chemotherapy has begun is controversial due to concerns about damage to sperm or poor likelihood of success. True or false? Yes. Yay! That's another one. She can have some meals.
Oh, yeah.
Okay. That answer is true. So it is, it's recommended that you bank your sperm prior to starting any type of treatment. However, there are sometimes when a patient might be rushed and have one treatment and their doctor will still sign off on the fact that it's okay for them to go ahead and preserve. So really that's something that we don't educate on. We get back in the doctor's hands and we say, okay, if your doctor's okay with it, then we're okay with having you submit an application for our financial assistance program, which we're going to talk about. But really it's a conversation that needs to happen between the doctor and the patient. Next, we're going to talk about some of the preservation and parenthood options for men. And so I think everyone by now, maybe, knows what sperm banking is. It's actually going to a physical location and leaving a sample of your sperm, your specimen, for later use. That then the fertility center will analyze your sperm, they'll check your sperm count, make sure that it's worth freezing and storing for several years or for a year, however long until you need it. So that is really the most common option. It is a standard procedure, and so we've got standard and experimental. So there are one of these that we'll talk about that is still experimental. There is testicular sperm extraction, and so that is for maybe men with really low sperm count, or that they could actually go in and they could just get just a little bit of sperm, what might be available. And so there's a procedure now that's called ICSI. So even just one sperm and one egg, you can make an embryo and can be pregnant, a female can be pregnant down the road. It's expensive, but it's definitely a possibility. There's electroejaculation, so that's a procedure that's done in a doctor's office or a fertility center that if a man cannot ejaculate on his own, then that's a process that can kind of help make that happen. Testicular tissue freezing, this is something that is experimental. This is the option for prepubescent boys. So this is taking a little bit of testicular tissue and then using it, analyzing it, and then using it later down the road. And then these are the next four are after treatment. And so there's natural conception. Not everyone needs the use of frozen sperm to have a baby. Men are lucky in that potentially after cancer treatment, their sperm count could come back. And so that's why we recommend that they get their sperm levels analyzed after treatment, because a year, 5 years afterwards, then maybe they don't need any help at all. And so, but it's a safeguard to have your sperm stored. You don't want to just say, oh, I'm going to take a risk. Like we always say, it's better safe than sorry to have it available if you need it. Assisted reproduction, so that's any time that you are using a fertility center to help make an embryo. So using sperm and using an egg, and using a fertility center to help make that process. There's also donor sperm and adoption. So donor sperm, individuals can go to a sperm bank, they can actually choose by characteristics or traits or whatever they're looking for to help make their embryo. And then there's also adoption. And now we have another trivia question. So, true or false? The egg is the largest cell in the body made mostly of water.
True.
Yay!
You're the winner of a lovely phone cover.
Can we expect to see that on your phone?
Gosh, now that I see it. Sure.
right, great. So this is true, and this will come up when we talk about egg freezing, is why this is kind of fascinating. So these are the options for women. There's embryo freezing and egg freezing. So embryo freezing has been the standard for many, many years because it's been successful, and we know it works, and there's been thousands and thousands of births worldwide from embryo freezing and using frozen embryos to get pregnant. Egg freezing, on the other hand, is something that has been experimental up until last October. And so the American Society for Reproductive Medicine in October decided to remove the experimental label, and that's because there had been so much success with women getting pregnant with their eggs once the eggs are thawed, and then using them to create embryos and then to get pregnant. So this is huge because it makes a big difference for women that are diagnosed with cancer. Before, it was encouraged that they had a partner or that they used donor sperm to make an egg. So if you're 20, 21, and you don't have a partner, then do you want to use donor sperm? Maybe not. Maybe you want to wait and see. So this means it opens up a lot of opportunities for younger women to preserve their eggs. Actually, women even of all ages. It's more successful when you're younger. As you get older, the quality of your eggs changes, and so some doctors will recommend once you hit a certain age that you do go ahead and try to freeze embryos over eggs. The part about the egg being the largest cell made up of water, the reason why that is interesting is that it was so hard to freeze an egg and then thaw it. And so now they've perfected the freezing process, and which has led to more successful births using the eggs later. Any questions about those? Yes.
Why, to me, I don't know, maybe this makes sense, but why did embryo freezing come prior to egg freezing? You would think that it was in the reverse, or was that just because they put those together first? Did they manage to preserve those first?
You know, I think that's a great question. I don't know if I...
I think it's the technology. So embryo freezing is a common part of IVF process in general. So some of the first embryo freezing was done for couples who were infertile just by natural means and need to go down and have assisted reproductive support and getting pregnant. And so the first route for doing that was embryo creation in a lab. And so, you know, when somebody stimulates you and you have lots of eggs, they would make a lot of embryos. And so they didn't want to discard any embryos, so they would freeze them. And so that's sort of the trajectory of how embryo freezing was sort of the primary thing that had been perfected more and more because it's a common treatment for people who are infertile in general.
Is there any sort of political focus at all about that there wasn't a person?
There's not a partner. Mm-hmm. Yeah, so there are a lot of the social factors involved with either being a single.
And there are some hospitals and reproductive centers that won't allow egg freezing.
Yeah, and there's actually probably right now 50 to 60% of fertility centers are doing egg freezing, but there's still a large number that are not. And with the state laws, there are different laws regarding what can be frozen. Can eggs be frozen? Are embryos human life? So there actually are 2 states that we don't work with for our financial assistance program, and that it's because of laws of freezing. So, but science has come a long way, and they're doing really neat things, and figuring all of this out and what works and what doesn't work. Some of the other options are, well, the next one, ovarian tissue freezing, which is really fascinating. They're taking out a woman's ovaries, and they're taking strips of the tissue, and they're analyzing the strips. They're taking it into little small pieces, and then they're freezing that, and then using that later in hopes that once it's reimplanted back into the woman, that then it would start creating eggs. And so there's the neat thing about this is that they will freeze it, or they could actually implant it in a woman's arm or somewhere that's full of blood vessels, and that it might, would survive on its own within the arm, and then they could use it later when they needed it. So science, they're doing crazy things with science. It's really amazing. But then also, ovarian tissue freezing is the only option for prepubescent girls. So it's still considered experimental, but there's an option, so that's good. And there are also concerns about reimplanting certain cancer types into a female's body. So different leukemias, there's still discussion back and forth as if that could cause cancer to come back or to grow again in the future. So there is some controversy around this. There's also ovarian transposition and suppression, radical trachelectomy, and then we've got the next few are just the parenthood options after treatment. So similar with men, natural conception, some women might not need help. In vitro fertilization, using donor eggs or embryos, and or having a surrogate, having someone else carry your child if you cannot safely carry to term. And then adoption. Any questions on this? Great, so this slide is going to go over estimated treatment costs. I just thought it would be really helpful for you all to see how expensive some of these procedures are. Sperm banking is one of the cheaper options for men, and it also, these prices are going to vary geographically. So New York and California, their prices might be higher than in North Carolina or Florida. You can see that embryo and egg freezing are around the same price, and that price does include the cost of medications, and medications are usually around $4,000 to $5,000. And most women, just so you know, will take about, they will need a cycle of medications, and what the medications do is it helps stimulate their eggs so that when the doctor goes in to harvest their eggs, then they have a lot. And so it's they want to make sure that they have enough to either make embryos with, or to do half eggs, half embryos, or just to freeze their eggs, so that, because you will lose them in the thaw process. The one that I've found the most fascinating in the last 6 months is the cost of surrogacy. So we have had more women reach out to us that can't carry their own child, and they need help with a surrogate, and it is so expensive. So $60,000, $80,000, I had women that were asking if they should take out a lien on their home, or what to do, because there aren't really financial assistance programs right now that are covering these costs. There's some that might provide $2,500 here or $5,000 here, but $5,000 when you're looking at $60,000 is insane. So there's legal costs associated with that. There's counseling costs associated with surrogacy, and then also adoption can be very expensive, and that depends if you're doing international, if you're going to do domestic, if you're going through a private agency or a public agency. That can be, those are challenges, and can be hard, especially after you've just finished with a cancer diagnosis and treatment and you're ready to move forward, and then to be faced with these costs in addition to what you've already gone through. Do you have any questions about these costs? Yes?
Have you considered partnering with faith-based organizations to help facilitate adoption and reduce that burden of cost?
Well, so right now we're actually working on how we can build out our post-treatment resources. And one of the things that we had thought about were reaching out to surrogacy groups and see if they would discount their services. And maybe not a formal partnership, but just kind of similar to how we have our financial assistance program set up, reaching out to these groups to see if we can advocate on behalf of our patients. So that's a great idea. We don't have anything in place right now, but we do have Jamie, who is going to be working on post-treatment resources from now until December. Okay, so for those of you that don't know, we do have the Fertile Hope program for men and women. So this is one of those areas that helps with the financial costs associated with fertility preservation. So this is a navigation program. It's one of my favorite program because it's a way for us to give hope to all of these people that have just been diagnosed and to give some positive news. So what we've done is we have a network of over 350 fertility centers across the U.S. that are willing to give a discount on their services for patients that we approve through the program. We also have a partnership with EMD Serono, which is a pharmaceutical company. It's one of the top 2 pharmaceutical companies for fertility preservation drugs. And they are willing to offer 1 cycle of free medications for women. So $4,200 for each woman going through the program of medications. And then we have our application process, which does have eligibility requirements. It must be prior to treatment. They must fall below a certain financial eligibility criteria. Their oncologist must say they have a cancer diagnosis and that treatment's going to affect their fertility, and then they must have a fertility doctor if it's a female. Once the application is then processed and approved, which usually takes 1 to 2 days once we have a completed application. Then the client would receive the discount and free medications. If it's a woman, if it's a male, they would receive a discount. And then they would also receive access to all of our all of our navigation services. So we stay in contact with them just to remind them about our other services, because once we have them on the fertility side, they're focused on fertility, they're focused on their diagnosis. They're not thinking about medical bills, emotional support, counseling, any of that. And so we do follow up with them just to kind of give them gentle reminders about our other services so that they know that they're a part of our larger organization and that we're here for them if they need us. Does anyone have any questions about this?
What's the time frame from point of application? How long does it take for someone to apply and get approved?
So once we have a complete application, it's 1 to 2 days. We can actually do a same-day approval if it's an urgent case. And we do have women that come through that are urgent that might need medications the next day. And so right now we overnight medications Monday through Thursday. And so as long as we have their application by Thursday at noon, they can get medications by Friday that could help them through the weekend. We do have, let's see, last week I think we had about 35 pending applications, which means we have both males and females that have submitted portions of their application, but maybe they're not complete. And so each week, someone on our fertility team, Jamie or Ann or myself, we will reach out to these clients to let them know what we might be missing or answer any questions they might have, or just remind them that we do need tax paperwork, or sometimes, you know, it can be a mother of a son and they're just overwhelming and stressful, and they're just getting all of the pieces of their puzzle figured out. And so we just try to offer reminders. But yeah, last week was a pretty busy week. Last year we approved 863 men and women for the program, and this year I think we were hoping or thinking around 1,000, so we'll see how that works out. But
And what percentage are turned down when they apply for the service?
not many. We do what we can to help patients get approved. So if they're over financially for, let's say, 2012, then we will try to average 3 years and see if that will help them fall below. If they are, we have process in place if they've been unemployed for 6 months, or we can review them as a case-by-case basis. But the ones that we might close might be because we haven't heard back from them after 6 weeks, and we will close an application. But we'll reopen it if they call us again, if they come back and they're less stressed, or a lot of sperm banks will do retroactive approvals, which means they'll honor a discounted rate while they're waiting for a letter from us. And then if they don't ever get the letter, then they will bill the patient the full amount, which then we might hear from the patient again because it's expensive and they want a discount. So women, the denials would most likely be financial, or that they could be post-treatment, which is an area that we're working on trying to get included. Women, once they've been rushed into treatment, they've had treatment, and then they're on the other side of treatment, a lot of them could be at risk for early menopause. So then their doctors are going to recommend that they preserve at that time before they hit menopause. So right now our program is pre-treatment. However, we've seen an increase in requests for post-treatment, this certain population of women. So we're hoping to pilot that with EMD Serrano in January, with just one fertility center, just to see how it works. And so EMD Serrano is on board. They just want to know what to expect as far as growth, and like how many women would we really be reaching out to us and wanting these medications, and can they sustain that part of the program. So, and then we also run into a situation with oncologists. We have language in place for the oncologist form that states that there aren't contraindications to the female going through with fertility preservation. And so for breast cancer oncologists, there is a concern with the female undergoing hormone-stimulating medications, especially if their cancer type is hormone sensitive. So, but if we ever have to deny someone, then we'll work with them to help them find other resources that might help. And we'll still advocate with the fertility center to make sure they'll still get a discount. And so far we haven't seen any issues or upset with that.
Do you think it's safe to say that some people just select out? They may not even apply for the program if they look at the financial criteria. I know this is oversimplifying it, but last year we had over 2,000 people reach out to us around fertility, but then 863 were approved. It's not that black and white. Some of those people may have just made a decision not to because it wasn't a priority to them.
Yep. I think that, yeah, I think if they do see the eligibility requirements, maybe they don't fit them, and so maybe they wouldn't apply, or maybe they didn't have time, or I think there could be a number of different factors that could come into play.
Are people coming in through navigation? Are they going in Fertile directly? Are they being referred to their oncologists? Like, how do people come in?
All sorts of ways. So they could contact us, navigation, phone, email, or in person, and maybe that's something they hadn't thought of. And then Guadalupe would educate them on have you considered fertility preservation, and then she would talk to them about our program. They could Google fertility and cancer, and they would see the Fertile Hope website and get information that way and learn about our financial assistance program that way. We do have a lot of referring oncologists, a lot of the same referring oncologists that will send patients over, and then also fertility centers. And there are lots of nurses out there that act as champions for fertility preservation, so that's kind of another way that they send people to us. Yes? Well, so there's 3 parts for a male application and 4 parts for a female application. So women actually need to have gone and had a consultation with a fertility doctor, with a reproductive endocrinologist that can select the medications that they would want the patient to receive, and men don't have that. So, and if they don't have a fertility center, then we would help find one that is a participant. And if they're not a participant, then I would reach out to the fertility center to see if they would want to join and go over the benefits of joining our program and the good that they would be doing by helping their patients and helping the community. Any other questions?
We see more men than women and women than men last year.
It was almost, I think it was slightly more women, but it was almost an even split.
I don't know if we're going to get this, but I'm curious about what progress is being made to add kind of coverage to, okay.
Transition, Rebecca.
Thank you. Great timing.
Awesome. So I'm going to spend a couple of minutes just talking about what we are doing cross-functionally within the organization to make some systemic change in the country around adding fertility preservation benefits to insurance policies. And so one of the reasons why it's such a financial burden, as Ashley described, is because insurance companies are not including fertility preservation as a covered service. It has a lot to do with basically the fact that somebody hasn't yet undergone treatment yet. So how can somebody be infertile? So the standard definition of infertility is having gone 6 months to a year with trying and unsuccessfully reproducing. And so because cancer survivors are not yet infertile, this coverage was something that was basically denied to these individuals. So in 2011, our organization partnered with Cancer Legal Resource Center to come up with our position statement on insurance coverage of fertility preservation. And so a lot of this information is documented on some lovely case documents on our website, but I wanted to highlight just a couple of things that are our focus area. And so our goal was to work with existing insurance companies to expand their coverage to include standard fertility preservation services. So the standard word was actually a really, really big word because insurance companies don't necessarily want to assume the risk of treatments that are not the norm. And so with egg freezing becoming standard in October, if an insurance company had actually expanded their coverage policy to include this, now egg freezing is just a part of that coverage. So we specifically made sure that we wanted insurance companies to specifically say the standard language, and we didn't want to necessarily drill down any more further than that, so that we'd be more inclusive of any of the policies. So this position statement covers a couple of things. Basically, we wanted to address the issue of parity. So it's very, everybody knows here that doctors are on an oath to do no harm, but in fact, cancer treatments do cause harm, and there are a lot of other services available to survivors that help them. So for example, breast cancer, reconstructive surgery, nausea medication, access to wigs. These are all services that are available to cancer survivors under some insurance plans. And because it was basically recognized that the cancer treatment was causing iatrogenic harm, basically harm due to medical treatment. And so we felt as though, well, if these things are being covered, why isn't fertility preservation also included in this? So we were looking for parity among guidelines and insurance language. The benefit already exists. So fertility preservation is covered as part of cancer care with the exception of sperm and embryo preservation. And the preservation services are things like ovarian transposition, which actually covered in one of the other slides, ovarian suppression, things that would actually be able to, and gonadal shielding. So things, if somebody is undergoing radiation therapy, during that process, there will be a shield that will help cover and defray the radiation from the reproductive area. So that, in essence, is a fertility preservation option that was covered under cancer treatment in insurance policies. And so our idea was, okay, well, you already have this covered under your cancer language. Let's add fertility preservation as part of that as a covered service for cancer and not necessarily reproductive medicine, because this is, in fact, an issue related to cancer. Low usage, low cost, and positive return. So while we see the impact of cancer in those reproductive age to be really, really, really high, in terms of the insurance coverage world, the percentage of their clients that they would serve is actually relatively low compared to their global coverage base. And so in terms of a financial case to give to insurance companies, this was one of the key things we wanted to tell them, and that, you know, this is actually sort of a non-issue, because even if you added this, the number of people who actually access this benefit is so low, it really wouldn't cost you all that much, essentially. And so based on this case for support, Lindsay Beck, who we referred to earlier, spent 2012 and some of 2011 actually approaching insurance companies and asking them to include a preservation benefit. Nobody turned her down. Many people actually did say yes, and she would go to private organizations and ask them to add it into their coverage policies, and they all said yes. The trick is different policies have different standards, different enrollment times, different ways you have to add these things, and so it's not necessarily been a global solution. But more and more insurance companies are saying, okay, well, yeah, we just didn't know about it. We just didn't even think about it. So thank you so much for raising this to our attention, and we'll now consider this as part of our benefits plan. So to date, there are about 2 million lives covered based on all of the work that has been done with Lindsay on our behalf to advocate for this policy coverage. So it's really, really exciting, and I think more and more is going to be done in the future. And Ashley did allude to a lot of state mandates are now coming up into place. How, you know, that legislative work makes systemic change, as well as the insurance private policy world as well. So any questions around that? Cameron, you might even be able to answer any specific questions about it. Awesome.
Great. Okay, so we just have one more thing that we want you to be aware of on the horizon. It's our fertility training that hopefully you will be seeing later on this year, and I'm sorry, definitely next year. So what is it? It's an e-learning course that is designed for healthcare professionals to teach them about fertility preservation options and risks so that they can talk to their patients about it. The target audience is healthcare professionals, could be also hospital administrators, nurses, social workers, anyone that's interacting with clients where they could have these conversations. There are 2 different sections of the fertility training. So there's going to be the fertility education piece, and then there's also a fertility toolkit. And so the education is going to be different modules, just primarily focused on fertility risk, fertility options for patients, and how to have these conversations. The toolkit is something that oncology centers could actually, it's a step-by-step guide where they could incorporate fertility preservation into their standard practices. And so it's something that Sarah has been working on, been dedicated to, and it's really awesome, the training and the toolkit. But it has kind of some processes and procedures in place as to how to implement this type of program into your center. The desired outcome is that there's going to be more people across the US talking about fertility preservation, that more patients will understand their risks and options, that more people will know about Livestrong and our Fertile Hope initiatives, and more people will come to us with questions or concerns and get the right information that they need about preservation or any education, that they can really speak to our services and what we can do for clients. Anything you'd like to add to that? Woohoo! So what can you do? You can educate patients, partners, programs that you work with about our fertility preservation services. If you have friends that are in fertility centers, sperm banks, anywhere in the U.S., feel free to have them contact me, and I would love to recruit them for the program. And then also we do have our fertility brochures that are for cancer survivors and patients. That is a brochure that goes over risks and options, and it's available in English and Spanish. You can send it to all of your groups, or they can order online in bulk quantities. And so that concludes our presentation. We do have some goodies for you all. So make sure you take one. Yes?
Is there anything in a copy of this deck of slides?
Absolutely.
To facilitate as we talk to donors? Or
Sure.
members?
That would be great.
Are we going to continue to call it Fertile Hope or Sharing Hope, or use their logo?
Great question. Timing could be perfect. That is something that we are currently working on in terms of how do we, talk about our fertility programs to patients and healthcare providers. And so we are closely working with marketing to make those determinations about how we either do or do not best utilize, the Fertile Hope brand itself, and how we can actually do a better job at associating our fertility services with Livestrong and that brand. So I think we'll likely see more and more talking points around that, about how we were trying to stress Livestrong and fertility together. So, more to come.
Yes?
Do we have any data on how many babies have been born as a result of our program?
We do not. It's in our survey that we're doing. We now do 2 different surveys. So we do one for a group that's been approved within the last year to find out about their experience and the process of our program, to try to make process changes and make it a better experience. And then we have the other one that's a long-term survey, so that we're trying to find out what they've done with their eggs and embryos, if they've used them or not. And so we'll have more data, I think, in the years to come.
You definitely get some anecdotal data. People will.
Right, we do have, like Sarah Lyle, who's one of our, one of her stories is one of the videos at livestrong.org/Sarah, and it talks about her story, and she went through our services, and her sister-in-law carried her baby.
One thing about that Lindsay Norbeck would always say is that it's not necessarily about the babies. So one of the outcomes about the program is that people are educated and know that there's a risk and have the moment that they could take to make a decision about preserving or not. So counting babies is great, but there are also other parts of the program that we're trying to get at.
I did also, I did bring an at-home sperm banking kit, if anyone wanted to look at that. This is also an option for men where they might be in a rural area, or they might be stuck in a hospital, or they might be young and uncomfortable and not wanting to go into a sperm bank. And so we do have a kit as an option that they would also get a discounted rate on, and all of the instructions and how it's used. And so it's a really great option as well.